Thanks everyone for joining us today, and welcome to our webinar. And the focus of today's presentation is some perspectives from the intensive care unit around the challenge of assessing patients for pressure injuries and also staging pressure injuries as well. I'm Angela Jones. I'm the Chief Operating Officer for Monash Partners Academic Health Science Centre, and it's terrific to have you all online for this webinar. Monash Partners is a partnership of 12 organisations, and we exist to try and support collaboration, particularly around the challenges of our health services, and certainly pressure injuries rate as one of those big challenges, and they're a cause obviously of significant harm to patients, and a lot of effort in hospital settings is being put into addressing that. We're accredited by the NHMRC as a collaboration centre, and we're delighted to bring you this presentation today. I'd like to start by acknowledging the traditional custodians of the land on which we're standing and meeting today, and in the spirit of reconciliation, I pay my respects to elders past, present and emerging. We extend respect to any Aboriginal and Torres Strait Islander people joining us today. Wherever you are, we acknowledge and pay respects to our First Peoples. Before we get underway, just a little bit of a snapshot of today's program. In a few minutes, I'm going to hand over to Professor Carolina Weller. Carolina is a professor with a huge amount of experience in wound care and based at Monash University, and has been funded through the Medical Research Future Fund to lead a Monash Partners flagship project around pressure injuries across our health services, and Carolina is going to speak to that for a few minutes, followed by Victoria Team, Dr. Victoria Team, who's a Monash Partners Wound Care Fellow, and Victoria is doing some terrific work with health services around pressure injury prevention and wound care. And then we're going to move over to a presentation from two of our senior nurses from the intensive care unit at the Alfred Hospital. The Alfred Hospital is one of the lead partners of Monash Partners Academic Health Science Centre, and Sarah and Nova have kindly agreed to join us today and present on some of the work they're doing in what is a very large ICU setting, and some of their experiences and innovations from the front line. We'll then move into a Q&A where there'll be the opportunity for you to pose questions and for us to answer them, and Carolina will provide us with perhaps a bit of a summary at the end with some take-home messages. We'd also value at the end your suggestions around future webinars. These events are proving to be really popular. We want to make sure that what we offer is in line with what you really need. So any suggestions at the end would be really welcome. I'm going to stop sharing my screen now and hand over to Carolina, who will share her screen and kick off with her presentation. Thanks, Carolina.
Bye. Okay, now that I've sorted that, can everybody hear me? Whoa, that's pretty impressive. Great. Thank you so much, Angela, and thank you everybody who has joined us for our webinar today. We're trying to keep it nice and simple, well, succinct, because we know you're very busy clinicians, most of you. And what I'd like to do today is actually share with you a little bit about the work that we were funded to do about building capacity to try and optimise. Let me see, I'm just going to move all you people so I can see my slide, sorry. There you go. Building capacity to optimise pressure injury prevention and surveillance, and we've done that across 4 Monash Partner health services. Let me just move that over there, that's good. Okay. Now, I think if I just do that, okay. All right, this was my problem. I wasn't sure whether, oh, here we go, lovely. Okay, so just a very, very brief sort of overview of why pressure injury is a really, really important clinical problem within particularly acute care services, but also right across the spectrum of clinical care, including aged care. Our particular study is looking at tertiary teaching hospitals, and we've used the National Quality Standards number 8 to actually sort of show just how important this particular issue is, because this is exactly what we're trying to do. We're trying to prevent patients from developing pressure injuries. Now, how we do that is something that we're investigating, whether people understand how to stage them and how to document and the accuracy of documentation. And then how do we actually manage pressure injuries when they do occur is a separate piece of work that we're not actually doing in our project, but will be a secondary piece of work that we plan to do in the future. And we'll be very interested to collaborate with anybody who's listening today if you're interested in that as well. So at the moment, what we're doing is we've tried to find out what are the challenges, what are the specific challenges and perhaps barriers about how clinicians can accurately measure pressure injury in that clinical domain. And what we have been able to identify by interviewing nurses and interviewing the clinical coders is that there is actually inconsistency about how we measure, how we assess, and how we code. And at the moment, one of the other things that we're working against as clinicians, I think, is this lack of accurate and reproducible measurement of pressure injury. Now, I say that because even though there is a pressure injury classification that we've sort of got together now with a group of organisations, including the European Pressure Ulcer Advisory Panel and the others that are listed there under that number 1 of reference, one of the things that's been quite obvious is that clinicians sometimes don't stage correctly. So they might see what is a stage 2, but because they're not sure, they may say that it is an unstageable pressure injury. That seems to be coming through quite a lot. And as you can see, the different stages there: 1, pressure injury, which is no broken skin; 2nd stage there, where there is actually skin loss; 3rd stage is where you've got full thickness skin loss, so it's actually going now deeper. So each of these is getting worse. And then stage 4 is the one where we've not only got tissue loss, but sometimes muscle, and it can go all the way down to bone or tendon. Now, those 4 are quite sort of, for a clinician who's been working with people with pressure injury, that probably isn't as difficult as if you saw something with necrosis over the pressure injury, or if you found a deep, if you sort of suspected a deep tissue injury, because we can't actually see underneath, so we don't know. So one of the things that we're actually looking at in this particular study is we want to see, well, how are these things documented? And we have done a little piece of work which was done initially at the Alfred, probably about 3 or 4 years ago now, right across the hospital, where we looked at the different pressure injury data sources of how things are recorded. And things were quite different depending on which data source you actually looked at. The stages were different. And so what we're doing now with this particular piece of work, we're actually looking at not only the Alfred, but we're looking at Cabrini, Monash and Peninsula Health as well, so that we can actually look at 3 different types of data. That includes the incident reporting data, the medical record coded data, and in some places the PUP study, the pressure ulcer point prevalence study, for inpatients on a certain day. Now, not all hospitals do that, but it's actually a really, really important source of information for us. So where we can get it, we've actually been able to collate that information. And one of the things that we'd like to be able to do in the future, and it isn't happening at the moment, and there is a need because there is a gap between this harmonisation approach, so that we can actually measure like or assess, measure like for like, so that it doesn't matter which system is used, we're going to harmonise how that's going to sort of be put together so that we can compare what's happening from hospital to hospital, because at the moment, depending on which data set is chosen, you can actually, have that incidence and prevalence rate of how many at a certain time. That can change. And then one of the other things that we're trying to do, and it's taking a little bit of sort of unraveling, and that is to identify how we can align the pressure injury assessment tools and those coding definitions. And that's one of the reasons that we're actually interviewing not only nurses for this study, but we're actually interviewing medical coders to be able to get a better idea of perhaps what could we do to improve the way nurses who are at the clinical coalface, to actually make sure that we are actually assessing accurately and systematically, and we're actually bringing the coders in so that they understand how best to document that when we're actually putting things into a data repository. Now, stage 2 is actually is to identify these barriers and enablers, as I've mentioned, to assessment, documentation and coding. And so far we have interviewed 32 nurses across those hospitals, and we've also interviewed 16 clinical medical coders. So we've got a good sort of span of people from each of the health services, and currently we are collating and sort of putting that information together so that we can get some clear information that we can hopefully report back to you before the end of this year. And those things will also help us to develop some training modules that will be offered on the Monash Partners site, and we'll be able to help clinicians with the information that we've gathered, as well as the information that's out there nationally and internationally. Now, that's just a very, very sort of brief overview of the work that we are doing with this flagship project. I would like to thank the people who have been, all the health services who have been very, very helpful in being part of this particular piece of work, and I look forward to bringing you the results, as I say, before the end of this year at the next or final seminar for the year. Thanks, everybody.
Terrific. Thank you for your presentation. I'm going to hand over now to Victoria. Victoria team has been working with the Monash Partners team now for about 2 years, and she's doing some work around building capacity across the Monash Partners health services. So Victoria, over to you to tell us about the work that you're involved in.
Okay, thank you, Angela. Thank you, Carolina. Can you hear me properly, and can you see my presentation? Yes. Good, thank you. So I will move straight away to our capacity building framework. So Carolina has discussed our research activities, which are important part of our capacity building framework, but there are a few other very important parts, including collaboration, workforce development, leadership, organizational development, and consumer involvement. I will also discuss some findings from my fellowship project, and I will focus on collaboration and workforce development. I will start from the beginning, when we have established a steering committee where we have representatives from Monash Partners, from Monash University, and also from our partner in health services, to identify the current needs and what is available in terms of pressure injury prevention and management. We decided that I interview the steering committee members, and last year I met with most people, particularly clinicians who represent on our committee. And I have discussed what is available and what are their current needs in relation to health education and workforce development. In the interviews, clinicians have identified a lot of a lot of issues, including risk assessment. They focused on the availability of risk assessment tools, and different health services use different risk assessment tools, but many health service leads said that they frequently teach their junior staff members to use clinical judgment on top of the validated tools, because frequently if they use only validated tools, they can underestimate the risk of pressure injury in patients they assess. They also said that they frequently encourage repeated risk assessment, or as they say, reassessment, because person's condition may change, and the change can occur really fast, particularly if a patient had a fall or even a planned surgery. And the participants shared their experience of using different risk assessment tools, and when they were conducting internal audits, they saw there is no change in pressure injury incidents, and people with low risk of pressure injury, according to the risk assessment tools, were developing pressure injury. So they have decided to introduce the SKIN bundle. And some of them said that the SKIN bundle worked really well for them, and they said it was magical. But there were some other opinions, and our partners from ICU said that the one-size-fits-all approach doesn't always work. They have noticed that, and they knew it long time ago, that there are low and high risk patients which have different needs, and they have discussed that also SKIN bundle works. They focused on the cost of implementing this bundle, and also on the waste of using unnecessary materials. And I have placed this classification of pressure injury once again. We have also a good discussion of different issues with classification and staging, and many people I have discussed it with, they said everything is clear when you see on the picture, but in real life, when you're trying to assess a pressure injury, sometimes it may not look exactly as one on the picture, and this is the main problem. They have discussed the most common problems, including that deep tissue injuries were still classified as stage 1 or 2, and incontinence-associated dermatitis has been classified as a pressure injury. And even during training session, they said that there are a lot of disagreements. And it's not only among junior staff that they have a difficulty to match the image of pressure injury to the stage. The disagreement also is among senior nurses who are well experienced. And I have included a quote for you. Grad nurses can come in quite confident, and they actually realize that they are not. So when we start doing little exercises with them, and as I said, we do a lot of imagery, matching the image to the stage.
Victoria, sorry to interrupt you. I think your slides are not progressing, and I wonder if you just might also take them to full view. It would just make it easier for people to read them. Just the magnifying the glass, if you just hit on that, it should take them to full view.
Okay. Okay, so can you read this text, or
I haven't got the full slide. I've just got part of it.
okay.
Maybe if you just yeah, that's much better.
Okay, good. So they told that grad nurses may frequently come confused, but also there is a benefit that they realize that it's not so easy to stage pressure injury. And she said, and also it's equally difficult to come to an agreement sometimes on some of that staging, and it's really complex. And they asked if we can develop some materials to guide nurses on how to improve their knowledge, and including how they can translate their knowledge into practice. And when I interview with clinicians who represent on our committee, they discuss that they have a lot of resources available already, educational resources for clinicians and for patients, and they run bedside training sessions, they discuss case studies, they do reviews of each pressure injury that was developed, they have simulation training, and they provide clinical advice and coaching. They have education days and workshops where pressure injury prevention and management is discussed. They have online training, which is based upon current standards, and which is mandatory as well. They have special interest group where they discuss issues in classification and staging pressure injuries, and they have induction programs for grad nurses, interns, and new staff. But they were a bit concerned that some courses are informal, and they're of course not uniform across partnering health services, and some participants said that they have waiting lists for training courses. So that's why we have decided to develop these webinars to cover this gap. And our previous webinar was on pressure injury prevention in COVID-19 patients with acute respiratory distress syndrome who are prone positioned. So this is our second webinar. And I'm really thankful to our colleagues from the Alfred Health, Sarah and Noah, who came and who would share their experience of classification and staging pressure injury. And the leads of other health services who we interviewed, they pointed out on importance of sharing information and resources. They highlighted the need for standardized practice, because they said that nurses move a lot across services, and it is important that they have a set of skills which is similar, and they know what is expected in any health service where they work. And they highlighted the importance of the uniformity of educational courses, and they were interested to collaborate and to participate and to contribute to education sessions that we will run at Monash Partners. Thank you.
Thank you so much, Victoria. Terrific to hear about the work that you're doing. We're now going to hand over to Sarah and Nova, two very experienced ICU nurses from the Alfred Health. And Sarah, I think you're going to share your slides. Terrific. So Sarah and Nova are both Associate Nurse Unit Managers. And over to you both now. Thank you so much for joining us today.
Thank you very much for having us. both. My name's Sarah and I'm presenting with Nova. As I said, we're ANUMs at the Alfred Intensive Care Unit, and we just wanted to give you a brief little chat about pressure injuries for us as a unit and what we've done to combat that in the last few months. So Alfred ICU as a whole, so we're one of Australia's largest intensive care units. We see about 3,000 patients per year. We're currently funded to 48 equivalent intensive care beds, which means we've got anywhere between 48 to 53 patients in the unit at a time. We provide a number of state services throughout Victoria, including burns, hyperbaric treatment, transplants, ECMO, as well as taking on our regular cardiothoracic sepsis trauma that comes through the door. We're split into 5 pods within the intensive care, with all specialties going to their specialty pods, with our ICU on level 1 being our original ICU and expanded into a 3rd level ICU 2 years ago. I've just got some data here to show you the sort of patients that we have and the patients that we're looking after. So this is from 2017 to 2019, and as disclosure, the reason we haven't put 2020 data in here is due to overall it was skewed across all hospitals from COVID. So just as a comparison here, so in the grey, this is 33 other tertiary hospitals from around Australia, and the Alfred data is in the red. So as you can see, we have a very high number of patients requiring ventilation, CRT, ECMO, as just as a example. But then over on the right hand side there, you can see that our length of stay for patients is much higher than any other hospital around, and that's a reflection on the complexity surrounding our patients' care. So they're, whether they're a transplant, whether they're a burns, anything like that, our length of stay across the board is a lot higher in the Alfred ICU. So our prevalence of pressure injuries. So as all ICUs know, pressure injuries has been a huge issue since the beginning of time within ICU. So this is just a bit of data to show you from the start of 2020 to the start of 2021, our overall pressure injury rates. So in the blue at the top is total number of pressure injuries. And this is inclusive of stage 1 pressure injuries as well. So as you can see, there's quite a big difference between the years as a whole, and our rates of pressure injury for anything stage 2 and above are actually quite low as a organisation. So this is ICU specific data from 2013 to the start of 2021, and this is a comparison of our rates of pressure injury, percentage of pressure injury versus our bed numbers. So as you can see, we have done things that have been really successful previously, and then we've had incidences of where we haven't been going so well. So as all organisations will know, you ebb and you flow. Some things work really well for a short amount of time, other things don't work so well, and you just have to tailor it overall for your patient population. So as you can see, in 2015 in August, things didn't go overly well on this PUPS audit. We had a bit over 40% prevalence of pressure injury within the unit, with a total of about 37 beds in the ICU, which comparatively was not great. As you can see from there, the strategies we put in place showed a really good result. But then again, over time, so we realised that we needed something to come in and we needed to act on this. So in November of 2020, with our 46 beds at the current time, we had a 30% rate of pressure injury prevention. And upon that data being received, we implemented the SKIN program, the SKIN bundle. And within the 4-month rollout across level 3 and level 1 intensive care, we were able to drop that rate by about 10% of our total number of pressure injuries on our next PUP round, which I think is a testament to the SKIN program overall. I'll hand over to Nova now to run you through our SKIN bundle.
Hello, everyone. My name is Nova. I'm one of the ANUMs at the Alfred ICU. So I will be talking about anything SKIN related. This SKIN initiative is a bundle that was adapted from the NHS, which was implemented roughly around 2010, 2012. The pressure injury prevention falls under the Comprehensive Care Standard 8 under the National Safety and Quality Health Service. According to the cost of illness study conducted in 2015, the treatment cost across all states in Australia in 2012 and 2013 was estimated to be roughly around 983 million per annum, and it represents about 1.9% of public hospital expenditures. So there's definitely a huge financial implication in treating and managing pressure injury. So the SKIN initiative basically talks about the SKIN assessment and integrity, surface, keep moving, incontinence, and nutrition and hydration. So for the surface, we really focused on the fact that whenever we have an admission from different hospitals, different wards, we make sure that our patients go straight into the ICU air mattress, which is the 20-cell air mattress. On top of this, we also have our heel wedges, our sliding sheets to prevent friction whenever we move our patients. We currently had an okay from the trauma team that we're able to put our trauma patients with unstable spine in this particular air mattress. We just have to remove the pump itself. The only exception to this rule are the patients who are going to hyperbaric treatments. Unfortunately, these particular air mattresses are not compatible with hyperbaric at the moment, so we still keep normal air mattress in ICU. The next slide talks about the SKIN integrity and SKIN assessment. So I'm sure most of us are familiar with this picture. So in ICU, we use a standardized SKIN assessment tool, which is the Braden and the FRAS. We make sure that our patients are assessed the first 4 hours of their admission. We document the pre-existing wounds and pressure injuries. We put in wristband for reporting if there are any. And we also do full SKIN assessment every shift. So not just during admission, but every shift. Yeah, this is what we use. For the next slide, this is one of the pictures of our, it's actually a video or a boomerang of our previous patient. Just a little bit of disclaimer, we had an okay from this patient and they were happy for us to use this video. And the reason why we're not wearing a mask yet is because this is pre-COVID time. So for the keep moving, we really focus on the mobility of our patient. As you can see, this particular patient has an ECMO, and we make sure that even our complex patients have the chance to be mobilized. It will require manpower, so it's a collaborative effort between the nursing team, the medical team, and the allied health team as well. On top of that, we also have Jordan frames, overhead tracking for our heavier patients to use to mobilize our patients. And we are at the Alfred, we are happy and we are lucky that we have the spotless team to do our pressure area care rounds. So it happens at 8 in the morning, 12 midday, and about 5 p.m. And at night we have at 8 p.m., 11 p.m., 2 a.m. and 5 a.m. as well. So we really do not have sort of like reason to not mobilize our patient unless they are absolutely unstable and can't be moved from the from that point. For the incontinence and moisture, these are the products that we widely use in the ICU. We use the Dermavine and the Molicare. And the reason why we have, and we also have the SSKIN spray, and the reason why we have a wide range of products is because it is very important for us to determine the difference between incontinence-associated dermatitis and pressure injury. On the next slide, we'll see the difference between the IAD and the pressure injury. And the rule of thumb really is if the patient is not incontinent, majority of the time the skin condition is not IAD. So we really have to have a look to see if it's a pressure injury because determining or knowing the difference is a key thing to be able for us to determine what sort of skin product to use. For the nutrition, we make sure that our patients receive a proper nutrition. Our nutrition team is involved in determining what sort of feeds the patient requires. We notify the medical and nutrition team if the patient needs to be fasted, so then their feeds can be adjusted. We also have the fasting clock time, so we escalate to the medical team if the patient is fasted and on requesting theater time. We standardized and we have a protocol of not fasting our patients that are not having GI surgeries that does not require any airway manipulation or proning. So you probably would wonder how we managed to implement the skin bundle in such a large ICU. It required a lot of collaboration from everyone involved in the care of the patient. We started with presenting the skin bundle to the leadership team, which involves the managers, the CNCs in the unit, and the ANUMs as well. We determined a starting date, which was December 1st, 2020, as our launch date. And once we determined that, we basically sent out an email announcing the skin bundle. Information dissemination was very important in implementation of the skin bundle, especially in a big unit. So what we've done was include this information to our start of the shift huddle. We made sure that every acronym and every component of the skin was mentioned. We also print out and laminated a lot of prompts to be put on the BMW, just to remind the nursing staff and the medical team as well that part of the assessment would be the skin as well. We also continue education every shift. So when the nurse in charge and the team lead goes around the unit and talk to the bedside nurses, we made sure that these are all mentioned as well, and we just reinforce this information. And Sarah will talk about the results since we've implemented our skin bundle.
This is just a screenshot of up to the 16th of April, where we were with our day tally count. So our level 3 was 5 days with no pressure injuries, and that's on a background of a 29-day run before that. General pod was also 5, cardiac 15, the trauma pod 9 on the background of nearly 60 days between their pressure injuries, which is wonderful results. So this is a breakdown of our PUPS audit. This is November 20, so pre-SKIN rollout, versus February 21. And February 21, SKIN had been rolled out on both level 3 and level 1 intensive care. So you can see that on the left-hand side there, patients with pressure injury for November was nearly 30%, and for February was 20%. So we'd managed to drop our total number of pressure injuries overall by 10%, which I think is wonderful. And that's including stage 1 pressure injuries as well. On the very right-hand side there, you can see the difference between patients acquiring pressure injuries in care. And I think this is the big one that we've been very proud of. So you can see that in November, there was a 40% acquisition of patients getting a pressure injury whilst in care, and we halved that in the 4-month period. So we as a unit are really, really proud of those results, and we hope that we can keep chipping away at that as we further develop our SKIN program. So our areas of focus. Standardised documentation is a big one. We have a staff of over 500 nursing staff within the ICU. So getting everyone to document, knowing what to document and how to document is really, really important. That's still an ongoing thing, as well as working out within our leadership group how to document the official formal SKIN assessment on admission. So that's been a big area of focus. Education, again, rolling out a program for a large number of staff you've got to have that ability to be able to stage pressure injury. So it was, again, getting a back to basic type thing of learning the difference of staging and the difference of IAD and that sort of thing. So we've been providing a lot of education, and from the SKIN program rollout, we've actually developed a wound care special interest group within the ICU itself. So they've been wonderful in being able to educate and implement the staging, but then also how to manage the pressure injury that you've found. Patient movement restrictions is a big one for us. So whether they're on ECMO, whether they've got an unstable spine, unstable pelvis, things like that, there are some patients that you just can't move the way that you would like them to move. So we do as much as we possibly can within the realms that we can, but that's always something, especially if we're waiting on external teams to come in and give their surgical input or anything like that. We are trying to streamline that and get a faster process of that happening. The early assessment after admission, especially if someone comes in and they're query COVID or they're in infection precautions, things like that, and if they're just genuinely very unstable, getting the early assessment done might not, we aim, but might not always get done in those 4 hours. So it's where, again, that's our aim, and we work towards that as much as we can. Procedural fastering times, as Nova touched on, is always a big one. It has been in intensive care for a very, very long time. We are, with the implementation of our fasting clock, we have been able to decrease the level of unnecessary fasting, which has been wonderful. And patients that are prone, last year with COVID, we saw a large cohort of our patients being prone, and anyone that's prone, it's a very high pressure injury risk and so we have a very clear protocol about how we move the patients. But again, with someone being nursed face down on the bed, you can't side to side turn them or do anything like that. So we are working towards making our proning, doing as much as we can with our prone patients. So what's next for us? Education, again, teaching nurses that are coming in, whether they're coming in as CCRNs or coming in from other organisations, the education of what is a pressure injury, the stages and the difference between incontinence dermatitis is one thing, but not only how to assess it, but how to manage it post. So what products do we use now, and what do we need a barrier spray versus do we need Molicare foam, things like that. Within the Alfred ICU as a whole, we are doing a big push of back to basics. So we can, as all of you would know, in ICU you can get caught up with the ICU side of a patient care, but we are pushing to get back to the basic nursing care, eye care, mouth care, pressure injury care, and it's the education around the importance of this, and realising that a patient's length of stay can actually be extended quite significantly upon developing a pressure injury. And the next big one for us is developing documentation of the SKIN assessment. So we're currently working with our EMR directors, as well as our wound care CNCs, to get the SKIN written into our electronic medical records. So in the previous slides, you saw our Braden and Fraz assessment on our EMR. So the photo here shows a template of what we hope the SKIN assessment will look like on the EMR. It'll be very, very clear that it's been done on assessment. It will be very, very clear if we have updated anything at all, instead of trolling through the notes. So that's something that's definitely in the pipeline, and definitely something that we want to happen as soon as possible. So now Nova's going to present a little case study. We thought we'd end with this, of one of our patients that we applied the SKIN program to.
So for the case presentation, we would like to introduce you to our 50-year-old female who was admitted to ICU post single lung transplant on the background of double lung transplant. She stayed in ICU for 200 days, which is a rare thing for us, but it definitely happens. It was complicated by sepsis, renal failure, high inotropic support, as well as physiological implications of being hospitalized for so long. Aside from the physiological implications, there's also an emotional and mental component during the admission that we had to manage. Because of the long stay, she became very non-compliant to the care that we were providing, particularly the pressure area care, which was understandable, because if you stay in ICU for so long, you just want to rest, you want to sleep at night, you want to go back to your day-night routine. As a result, this particular patient developed a stage 1 injury that progressed to stage 2. There was an overlap in her admission from the time she was admitted to the time we've implemented the SKIN bundle. So with the SKIN bundle applied, we found an improvement. So we made sure that her SKIN assessment was done. We had to work around her routine. Whenever she needed to be turned, we made sure that we cluster all the care that we needed to do. She was receiving good nutrition. She was on an air mattress. And lucky for us, she was continent and she had a good bowel regime. So every time she had to be cleaned up, she needed to sit on a pan. We do all the things necessary. We applied all the SKIN product that was necessary. And as a result, we discharged her to the ward with a stage 1 pressure injury. So we took that as a win, because it did not progress to stage 3 or stage 4.
Thank you, Nova and Sarah, for your presentations. Terrific to hear your insights from the front line. And we've got just a few minutes now to take questions, and I'm going to hand over to Carolina for the last few minutes just to facilitate some discussion.
Thank you so much, Nova and Sarah. That was so insightful to hear some of the things that you've come up with, and thank you for sharing your experiences and your positive experiences, how things have actually helped. I've got a couple of questions that I will ask that people have put up, if you just bear with me. So the first question from Rowena is, Is 2-hourly turning helpful with pressure injuries? So we'll just start with that one for Sarah and Nova.
Absolutely. It helps a lot. From my previous hospital, we did 2 hourly turning rounds, but obviously in ICU that's not happen very often because of the way our patients are at the moment. So if you're in an intensive care, there's a lot of team involved, and even if you want to do 2 to 4 hourly turns, sometimes it just doesn't happen. So to be able to make sure that these patients are still being turned, we do little things like lifting their elbows, lifting their heads, just focus on the bony prominences that we can move. But yeah, 2 hourly is optimal, but sometimes it just doesn't happen.
Thank you so much, Nova. I'll keep going through the questions, and then Sarah or Nova, if you wouldn't mind responding, we've only got another 5 or so minutes, so we'll keep going. How did you get engagement and buy-in from all levels of nurses in this project? And did you engage with the medical team as well?
So our engagement was really, really good. So we sent out an email to all the staff in ICU first, and it had attached there a breakdown of the SKIN program in it for them to be able to read through. We also made it very clear on our huddle. So each pod has a huddle for us at the start of every shift. And it was there then the consistent messaging of this is going to start. So for level 3, this is going to start on December 1st. For level 1, this is going to start on February 1st. And with that, plus the implementation of the prompts that we use throughout the unit on a BMWs, the nursing staff were able to, they were very, very engaged. It's something that they're obviously wanting to learn a lot about and wanting to prevent from happening. So the engagement was really good. And the medical team, yes, we have a really good relationship with our medical team as a unit. So we tackled this as a whole. And so in things like the fasting, for example, for us to be able to escalate to them and say, hey, my patient's actually fasted for the last 8 hours. They're on requesting time. It's then they take that on and escalate to that home team or that surgical team as well. So yeah, it's been a very collaborative approach across the unit, which has been wonderful.
That's fantastic. So nice to hear that. Now I'm going to just ask you some questions about the SKIN bundle. People are quite interested in that. So whose responsibility is it to complete the SKIN bundle? Is it only on admission or daily? And has the SKIN bundle been rolled out throughout the rest of the organisation at the Alfred, or is it only something you guys have been dealing with in ICU?
As far as I know, ICU is the only one who's doing it at the moment. It is an aim to hopefully introduce that across the organization. It's everybody's responsibility to look into the SKIN bundle. But what we're doing at the moment is making sure that the nurse in charge, the medical team who's on during that shift, and the bedside nurses are talking about the SKIN assessment. The SKIN assessment itself does not only happen during admission, it's every shift thing. We just have to make sure that if the main thing that we're focusing is if the patient is admitted to our unit and they have a stage 2 pressure injury, that it is reported, and we're managing it and making sure that does not going to progress into another stage. Right.
Okay, there's one specific question that's asking, at night when the patients sleep, this person's asking, can we just do every 4 hours change of positions if they're on an air mattress?
So within our unit, we do generally a 2 hour. It doesn't need to be a 2 hour turn. We have the turning teams that come around every 3 to 4 hours, and we'll do a full turn then. It's a change of position, so a change of pressure. So you can go from someone being on their side on the full turn with pillows or wedges behind them, then in the next 2 hours, just remove those pillows. So then that's the change of pressure. So it doesn't have to be a full physical turn. So that generally goes much better for our patients that are not that are awake. But yes, that it is encouraged if you can to do the 2 hour, to keep that 3 hour version. Yeah.
Now this one might be a little bit interesting. For your patients with with a length of stay of 200 days, so that's a fairly lengthy period of time, how do you balance pressure injury care and day-night routine, and how often did you turn her overnight? And I think you've partly answered that question, but you might want to just add a few comments to that.
So it was very challenging at the start, especially when she started to not really cooperating with the care. So what we've done was one of our clinical nurse specialists made a massive calendar. So we involve her in her care. We've educated her about the implications of pressure injury. It was a journey for us to be able to convince her to do all these things. We've managed to work around her routine. So because it was a trial between managing her day-night routine as well as prevention of pressure injury, that we just had to do what we needed to do. So when we knew her routine that every 4 to 6 hours she would wake up and use the pan because we had that bowel regime already. So every time she does that, we do our turn, do all the washes that we needed to do, apply lotions and moisturizers and everything that we can apply to, and put her on her preferred position. And that seemed to work for her.
Brilliant. Thank you so much, Nova. Now, I'm mindful that it's 1:01 and we promised you we wouldn't keep more than 1 hour of your time. There's one more question, and if you would please allow me to ask it, I'd be grateful, because I think it's an important one. So there are beds that can be manipulated to turn patients, not necessarily using manpower. Is there evidence-based data that this helps pressure injury? And then the other part is, how critical is the ease of access to documentation? And do you feel that the electronic medical record actually supports the frontline nurses?
I'll start with the second part of that question. The EMR based question. So for us, yes, having that documentation gives us a baseline to go from in terms of that patient's care. So if someone came in at home, for example, that's just been in his chair for 2 weeks feeling unwell, and he does come in with a bit of a stage 2 pressure injury, having that as a baseline, that we've done that SKIN assessment and having it right there and very easy to see, we're able to go back and say, hey, this was definitely not acquired in our care. He actually came in with this, and this is what we've done to be able to decrease his risk of pressure, and this is how we managed it from there. So I feel as though it's a really good
Sounds
support.
like it will be a supportive way. That's brilliant.
Yeah.
Do you want to answer the last the bit about manipulating the patients, and then we'll finish and close the session up?
I know exactly the beds that you're talking about. We do have a few within the unit. I think it's more, from what I understand it's more about the mattress that they're on rather than the actual bed that they're on. So the mattress that is the air mattress and has that evolving cells that move under the patient and can move with the patient, even if they move in the slightest way, then the air responds to that and moves the pressure itself, rather than the bed being able to do that. I think the bed is more for a nursing perspective, making it easier for nursing staff, rather than the pressure injury part of it, is from what I understand.
Thank you so much, Sarah. Angela has to leave us and I'll just close the session. Angela, if you need to go, I understand. Thank you so much for facilitating today.
That's a pleasure.
Okay, everybody, what I'd like to do is thank you for not only attending the session and for your questions and being involved. A sincere thank you to our speakers, Sarah and Nova, to give us that very, very timely and very, very important overview from an ICU perspective for pressure injury. You guys doing a brilliant job. Should really, you know, if I had a medal, I'd give you a medal. Hang on, let me see if I can give you a medal. No, can't find one. And Victoria, thank you for sharing some of the insights that you've been able to glean from the clinicians about what are some of the things. So if I just collate it very, very quickly, because I know and I'll just wrap up quickly. Perhaps the take-home message is that standard documentation across the whole hospital and then even across other hospitals, so that clinicians who are trained in pressure injury to this very best possible way. It doesn't matter whether you're in ICU at the Alfred or in ICU in Timbuktu in Victoria, wherever that hospital is. Or, you know, it doesn't matter because everybody's sort of talking the same language. And we're trying to harmonise a system perhaps that's going to improve the way we can look after these folk for prevention and for sort of tracking. That uniformity of education, I think, is going to be a very, very important element. And what I'd like to do is, for people who are still online, and I apologise we've gone too long, but I didn't want to stop Sarah or Nova, and I didn't want to not go to the questions because I think this is really valuable learning, and sometimes it's more valuable than listening to somebody like me telling you about what we're doing. You've actually got somebody at the coalface which is telling you. What I would ask of each of you is, would you be good enough to let us know what are some of the main things that you feel we can help you with as researchers? Like, you know, what would you like to hear about next time we put this seminar together? And we'll try and put those topics together and sort of send those out, and hopefully you'll be able to get some answers from an evidence-based perspective. So Steph, hello Steph, said device-related pressure injury prevention management assessment. Thank you, Steph. And anybody who'd like to add to that, please let us know, because we're here to help you. And I will stop at this point because now we're 6 minutes over, so we're probably into your lunchtime now. But thank you sincerely to Sarah and Nova and Victoria. Victoria Kay, thank you for overseeing and getting us on track and whatever. And to everybody else listening, thank you so much for making time to listen and also to give us your ideas. Thank you, everybody. Victoria might say something before she goes. No, you're okay?
Well, just I want to say thank you very much to Sarah and Noah and Carolina and to you. And Angela has left. Yes, thank you very much for your contribution. And we are really happy and people are interested and many people have attended. Yes, and the recording will be available on Monash Partners website. We know that many of people who expressed their interest to attend and who were registered were unable to attend because they are working. But once again, the recording will be placed on Monash website. And we are currently developing the web page where we will place all educational materials and our recording. Yeah.
So we've actually got somebody, Melissa Pincus from Monash Health. Thank you for your comment. Hopefully you've enjoyed the webinar. Thank you for your question, and we will be in touch. Actually, Steph Taylor works in ICU at Monash Health, so perhaps connect with Steph, because we're actually working with her quite closely on pressure injury education, and we'd love for you to be part of that. So just let us know. Okay, anybody that's keen in this area, we're here to help you. Okay, now I'm going because definitely we're well and truly over time. But thank you, everybody. Take care. Bye-bye.